This presentation focuses on a unique collaboration project between ROR, Radiation Oncology Resources, and Philips in an effort to investigate best practices. And in the spirit of a fun, practical learning environment, the folks at Philips sponsored a Pinnacle specific plan challenge prior to Astro this year. So we, ROR, in the spirit of looking at best practices for treatment planning, really specific to this one treatment planning system, facilitated the project through our website and began hosting this several weeks prior to the Astro convention in Atlanta. We collected the information and we presented the winners at the Philips users meeting on site. The goal of this presentation is to present the data, to recognize those high performers, including the top 3 scores, as well as looking at a detailed analysis and specific to this challenge, ROR's approach to the same plan. Clearly, we'd like to thank Philips for sponsoring the project and allowing this powerful learning opportunity to happen in the first place. More specifically, the pros team, which included several of the application support individuals and the research and development team, they also took part in the project. That is, they actually ran a plan and submitted it for scoring. And this is exciting because elements of a plan challenge, the way that we host it, provides opportunities for benchmarking and also examining strengths and potential areas of improvement, not only of the participants themselves, but in this case, looking at a really a drill down of the technology as well. So in other words, we're looking at things like IMRT versus VMAT or different optimization techniques that people may apply based on a similar set of parameters. So this produces really meaningful data and more than that, a great discussion on best practices. So Steve Boyd, affectionately known as et al. In all of our publications on treatment plan variability, he'll provide a step-by-step walkthrough of how he approached this particular plan on the second phase of this presentation. I'm really just here to give you a broad perspective of the project itself and to recognize those high performers. And then I'll pass the baton to Steve. He's going to go through everything from contours to optimization techniques and a breakdown of how he achieved one of those high performance scores. So I mentioned the word score, and if you're new to this concept or new to the plan challenge, briefly, I just want to mention that we've been hosting projects like this for the past several years, more specifically with the AAMD, the Professional Organization for Medical Dosimetrists. We've hosted a plan challenge annually around the national meeting. The process is the same as the one we've hosted here with Philips. Every opportunity we run this, we have an opportunity to participate and submit and collect plans from all over the world. The scoring that we use for this project is summed up in this publication on variation and plan quality. And this acronym in the top right corner, this idea of a PQM, is the scoring system that we use. It's known as a plan quality metric score. And really it's just a sum total of weighted, commonly accepted clinical metrics specific to a particular disease site. What this allows us to do is examine treatment plan quality more in beyond just a subjective way, looking at things like target coverage, organ at risk bearing, conformality in a quantitative way, and really measuring what that quality looks like to the best of our ability. And then beyond that, we're able to collect the data and look at things like variability with different dependencies. So what I mean by that is through the score that's generated, we can populate the data into what we call a performance record or a population distribution, which is represented here on the screen. And this provides a great perspective on what's possible, essentially. In other words, this yellow line represents an individual score on a backdrop of blue bars representative of the population of scores on the same data set or metrics. And we can provide things like the number of participants, the minimum score achieved, the maximum score achieved, the mean, the median, the standard deviation, things like that. The metrics that we use they look something like this. Now, this is a different example for, I think, a pelvis case, but the philosophy is the same, where we take things like target coverage, organ at risk bearing, global max location, conformity indices, and we assign a weighted score value to each of those, analyze the plan that comes in with a DICOM compatible software program, and then the sum total score is that PQM. This project specifically that we hosted with Philips, this Pinnacle Plan Challenge, had, again, global outreach. As you can see from the red markers on the screen here, this represents submitted plans geographically all over the world that came in. It was really exciting, and every time we host this project, it's clear that this is a great opportunity to see what clinicians are doing from all over the world. So we wanted to give you a snapshot of that perspective. Now, this is a movie that I'll play very quickly. This really goes through the challenge itself. So this is the data set that was offered up with the contours provided, not only the targets themselves with the prescription. It was a 3 PTV head and neck case, but you can see here on this video that also things like the parotids, the spinal cord, the brainstem, all the relevant organs at risk that were being analyzed were provided to minimize or really to get rid of that variability, because we know that if we were to have everyone contour, then it would just add another degree of variability. So as we traverse down through the axial planes, you can see that it's a common 3 PTV head and neck case, including supraclavicular nodes. The specific metrics that were provided are listed here. This entire page, as you can see, is dedicated to really nothing but targets. So you had the PTV 70, the PTV 63, and the PTV 56 with the assigned doses in the same plan. We also provided things like confirmation number specific to those targets to look at the dose wrapping or the conformality of the isodose line relative to that target. Things like global max location, all of those things were analyzed, provided a score. This page here represents a lot of the organ at risks that were provided. So the contours that you just saw had associated metrics that we really tried to base off clinically relevant metrics with acute late side effects, with common protocols that are out there. So you can see things like the spinal cord and brainstem. Those were actually built with a pass-fail mindset, and you can see a 0 next to the green bar. So what that means is if that metric was not met, it really was kind of multiplicative. It was a hard constraint. And so really the sum total score would have ended up being 0 if the cord and brainstem metrics were not passed. Because the tumor location was on one side, the contralateral parotid had a little bit more aggressive metrics associated with it, and we had some other mean and max doses that are common with head and neck IMRT or VMAT treatment planning. We also included things like posterior neck contour to evaluate the dose bleed off behind the cord. So a lot of very detailed metrics were provided up front, and as I mentioned, we use a DICOM compatible independent piece of software. This software is known as Quality Reports EMR. We could easily load the DICOM data in. Those beautiful reports that you just saw came from this piece of technology that ROR actually distributes commercially, but as you can see from this very brief video, we can bring in the plans via DICOM. We can look at and analyze the geometry of the beams, the segments of each beam, anything that's relevant here, the dose distribution. We can interact with the dose planes themselves and look at things qualitatively as well. So we're not just looking at the metrics, but we're also looking at the different things that we're all used to looking at in terms of a DVH or a dose distribution. We can interact with the DVH with that are relevant for the pertinent contours and metrics that we provided. We can also look and evaluate this PQM. So this is really where the power of quality reports is for us. When we run these plan challenges, we can quickly bring in the plans and provide a PQM score. We can look at each individual metric on a more detailed analysis, and then from there we can add that score to that distribution that I talked about briefly. And really that is how we're able to drive these projects very quickly and efficiently. Now here's the specific distribution for this particular plan challenge, and I'll spend just a minute on this. As you can see at the top, there were 44 plans ultimately submitted. We had over twice that actually of people that registered, but this includes IMRT and VMAT plans for this head and neck case that was just provided there on the screen. The max score, as you can see, was a 142.90 out of 150. And when we designed the metrics, because of all the trade-offs with the plan itself, a 150 score was really unachievable. The median score, as you can see, is listed here. There was a couple that didn't pass that hard constraint with a spinal cord brainstem, so that affected that statistical analysis there. So you can see the minimum score was 0, and the standard deviation was also provided. The great thing about this PQM is we can also look at other parameters. So we could look at, for instance, static IMRT plans versus SmartArc. And the blue bars represent those static IMRT plans. You can see the majority of the plans that came in were of that nature. We had 7 SmartArc plans that were submitted, but you can see that the max dose or the max score for each category there was very similar, probably clinically insignificant differences. And we've also listed the min score, the median scores, and the standard deviation for both of those. So just some really great data that you can look at and just kind of get a perspective on the project as a whole. Again, the great thing about doing things objectively in terms of a PQM score is we can correlate it with other data, not just looking at the differences in deliverability of plan, but things like we asked the question, what's your confidence level on a scale of 1 to 5, 5 being this master planner ability. With lots of experience, I'm very confident with IMRT or VMAT plans. That confidence level 5 is represented by these blue bars. And as we go down 4, 3, 2, 1, you can see that relative to the score, and it gives you just a nice perspective to look at. This is one of our favorite slides. This shows that global exposure and participation that we had with this project. And you can see the blue bars on top, and in this case represent the plans submitted from Australia. Some came in from Canada, from China as well, and also at the bottom here from the United States. We had 24 plans come in. There are a few countries actually that aren't represented on this slide. There were some singular data points that came in from countries like Germany, Italy, Spain, to name a few. But this slide represents where we had instances where more than 2 plans were submitted. Here's a breakdown of the years of experience. At the top, we have, relative to that PQM score, a distribution of the experience on IMRT planning itself. So 0 to 5 years on the top, and in the middle, represented by red, 6 to 10 years of experience. And then on the bottom, represented by these green distribution bars, we have 11 plus years of experience. And you can see the number of plans that were submitted with the max, mean, min scores, all the variables that we've presented before. So here's an interesting one. We asked a very simple question of what is your job role? As you would expect, I think, especially with the large majority of plans coming in from the United States, the biggest number of plans that we had come in were from people that qualify themselves as a dosimetrist. The red bars represent clinical physicists that were doing the treatment planning. We also had those, we separated out the tags of an educator, or we had some Philips colleagues that actually participated, which was encouraging. And radiation therapist category was also one of the labels that was assigned. And this, I think, had to do with a lot of plans coming in internationally, where you have kind of a shared job role where there's you're rotating treating patients on the machine and also doing treatment planning. Now, a project like this wouldn't be complete without a little bit of humor. We had a plan submitted by an individual named John Snow. And apparently, after speaking with my 10-year-old nephew, this is a character based off a pretty popular video game. Not sure what's worse, that the joke itself or the fact that the professional submitting the plan actually plays these video games, but there you go. So that's the last category relative to the PQM score. And now I'll wrap things up with, before we hand the baton off to Steve, with just a moment of recognition, really. And I should stress, and we talk about this a lot, that it's not about the high score. We really believe in this idea of benchmarking, that you can't improve what you don't measure. So this gives us an opportunity through our training programs that ROR provides to show that measured improvement through continuing education. In fact, we typically don't focus too much on the high score here, and a lot of times we don't even include our names as colleagues on the list when we host these projects. But this time, Steve's going to give a breakdown of the meaning of the PQM in more detail. You know, what does a 140 mean versus a 120? Those kinds of things, and provide a detailed analysis of his 138 scoring plan. So a lot of great information to follow here shortly. These are the scores above 130, also including the top 3 scores. They were recognized at the Phillips users meeting specifically, but we wanted to just give you a rundown, really in no particular order, actually alphabetical order by first name, but not in order of score. You can see the first and last name of every individual that was at about a 130 or higher, and Steve will talk about the relevance of that, and the institution where they work. So thank you to everyone who participated and submitted a plan. And finally, the top 3 finishers. You can see here Anthony Magliari, a dosimetrist from Siteman Center at Barnes Jewish in St. Louis, Vanessa Chestier, a dosimetrist from Quebec, Canada, and Samantha Price from the same place as Anthony from St. Louis. And I'll just kind of briefly show you some snapshots of their plans qualitatively and also their scorecard. So Samantha Price in 3rd place with a score of 140.75. You can see it was a static IMRT plan. In 2nd place, Vanessa Chestier with a PQM score of 142.17. And this was a VMAT plan, our SmartArc plan. And finally, Anthony Magliari with a score of 142.90, a static IMRT plan. So thank you again. And congratulations to those that did well, and we really appreciate everyone that took the time to submit a plan. We know everyone's busy, but we really find a lot of value in these projects. And again, thank you to Phillips for sponsoring the project. Right now I'm going to hand off to Steve Boyd, who's a CMD within ROR. And one of the common questions or requests, I guess, that we receive is for specific feedback on a broader perspective on the PQM score itself. So as I mentioned, what's that difference between a 130 or a 140 clinically? Those qualitative terms that we're used to looking at from DVH perspective or the isodose line perspective. And finally, he'll be presenting a step-by-step walkthrough of how he approached this particular plan and achieved a high performer score. We hope you find this valuable. We thank you again for your time and the support of this Pinnacle Plan Challenge.
Hello everybody, this is Stephen Boyd from Radiation Oncology Resources. Thank you for checking out the encore presentation of the 2013 Pinnacle Plan Challenge. The first thing I'm going to do is start off with a little story about our experience in Canada with the center. About 2 years ago, we went up to the facility to engage them in some training and the use of quality reports. And on the initial assessment on one of the plan challenge data sets, the 7 individual physicists did their IMRT plans, and you can see in the top left that their scores were significantly variable. So there's a really wide distribution in their department, even though they sat side by side basically. So after a little bit of training and some teaching with quality reports and some of the simpler techniques for uniformity and conformity and how to make the planning process a little bit more efficient, the same 7 physicists entered last year's Pinnacle Plan Challenge, and you can see that they all scored within 5 points of each other. But not only did they score within 5 points of each other, 12 of the top scores for the Global Plan Challenge were owned by 7 of the physicists from this particular site. So what they used to look like in distribution, sitting in the same department, now look like this. And they actually use quality reports for all of their clinical goals and clinical plans. It keeps everybody kind of planning the same way. So our plan challenge this year. The plan challenge this year was a 3 PTV head and neck, kind of a standard right-sided tonsil. As you can see here, there's in red the CTV 70, in magenta is the PTV 70. In blue would be the PTV 63, and over here on the contralateral side, in green is the PTV 56. we were inspired by RTOG 0522 to create a group of metrics that would help us analyze the plan. And this is what the metrics actually look like once we got them into quality reports and used the design of quality reports to do this. It made it very simple. We can actually kind of tell where the pass-fail regions are, what's acceptable versus ideal, and then the points that we associated with each particular metric. And in this case, there are 24 metrics in all. Now, the reason that we created the metrics, a few years back, when we first started the process of using quality reports and metrics to score things, there was the ability to game the system. And what I mean by gaming is you would kind of forget about some of the lower level objectives and just go for the high point values. So you'd get a high score, but you were blatantly disregarding some of the lower scoring items, such as serial slice dose, dose behind the neck. And these are very significant things, especially this image where you have circumferential dose. So as you can see, you're sparing the posterior spinal cord, but there's 4,500 centigrade wrapped around the entire neck. And obviously these things are very significant, and the physicians, I'm sure, wouldn't want the plans to look like that. So the design of our metrics and the score sheet allow you to get a snapshot of each individual metric, what the goal is, what the result was, the score associated, and then gives you a score. Everything in green is a very high level score, or a percent passing, and then as the colors go down the scale, it means you have less and less performance there. And then at the end you can see the total score. And actually this is my score sheet. So this I went through the same process using quality reports, attacking this treatment plan, and now you can see the score that I achieved. We're also going to kind of explain what a PQM means. So okay, so I got a 138 score. Okay, what does that mean? Is that number completely arbitrary, or does that actually have some type of clinical impact? Well, it does. And the trends of these scores seem to point to clinical viability. So what I mean by that are plans that score above a 130, let's say, generally have better target coverage, they have better organ at risk sparing, and they have better conformity, which means the isodose lines are tighter to the targets. There's not a lot of bleed off into the normal tissue. There's not a lot of dose islanding or dose pooling in areas where it doesn't need to be. The global max location is usually in the PTV. And, you know, sometimes the plans run a little bit warm. Now, I don't mean drastically hot. And even if it's, let's say your global max is 10% hot, if the 10% hotspot is in the high dose CTV, that's tissue that we're trying to kill anyways. So having a 10% hotspot in the, let's say in the shoulder, well, that would be a terrible thing, because that's tissue we're trying to spare. So the relative percentage for the hotspot is dependent on the high dose prescription. So, you know, a couple years ago, I talked to somebody that was really happy that they only had an 8% hotspot. So I thought, you know, wow, they got that under 7,700 centigrade. Well, it was 7,700 centigrade or 7,600 centigrade, but it happened to be sitting inside the PTV 56. So that's not a 8 or 9% hotspot. That's like a 25 or 30% hotspot. So where the hotspot falls is definitely important. What does a score under 120 look like? A score under 120 is typically kind of misshapen isodose lines. They don't hug the targets very well. They don't have good coverage. Usually the coverage for the targets is well below 95%. They're not achieving the organ at risk sparing that is achievable. There's a lot of inhomogeneity, and the global max location, as I was just talking about, was falling well outside the PTV or in other other targets or actually other organs at risk. And nothing really seemed to line up with the goals. So obviously, we've kind of discovered that a PQM, and let me explain that algorithm here. The PQM is a plan quality metric. So the number below, any numbers below 120, clinically would not be a plan that you would really want to use. And then the plans above a 130 are plans that you probably would be using in the clinic. So I'm going to play a little movie here, and this kind of shows the process of importing the plan in, looking at the quality reports, scoring mechanisms, and analyzing the plan. So here you can see with the quality reports, you can obviously go through any of the metrics. You can interact with the DVH, just like a lot of the planning systems. You can analyze the dose on the planes. You can analyze all of the aspects of your beam. So your gantry angle, collimator angle, your fluence map, control points, the extent of your fields. In the planes tab, just like planning systems, you can analyze the dose. So you can scroll through on any of the planes. It gives you a scaled color wash, which now the scale for the newest version of quality reports, the scale is much more detailed. And there you can actually see some of the dose sparing on the left submandibular. And you can see the dose off of the posterior neck for the lymphatic sparing, and the dose falling off of the larynx. Okay, so now we're going to start kind of talking about how I built my plan and some of the optimization contours that I use. Well, of course, one of the first things that we need to really pay attention to is the spinal cord and the brainstem. They're kind of the two heavy hitters for head and neck plans, because obviously if we don't spare them, it doesn't matter how good the plan looks from that point on. And because we have so many younger patients coming back for retreatments because of HPV or just how young they are the first time around, we really need to pay attention to sparing the spinal cord, the brainstem, and the posterior strip. I always use a posterior sparing structure, which basically runs up the midline of the back of the neck, and I make sure that I don't allow dose over 35 gray in that area. One of the things that we have to keep in mind, though, is when we use an avoidance structure such as this one, where we end it and where we begin it become quite important. In this case, if let's say the high dose target was in the nasopharynx or maybe the roof of the mouth, you could potentially be telling the optimizer that there's a free avenue to get dose to the target just by going over top of the avoidance structure and through the brainstem. So what I tell people a lot when I'm doing trainings or talking about planning techniques is I always say, when you use an avoidance structure, something like this, especially with a posterior rectum or the posterior neck, take the avoidance structures above and below your targets. That just avoids dose streaking through them. The lymphedema is a very important thing to touch on. A few years back, we mentioned sparing the posterior strip and not going above 3,500. In this case, you can actually see the 3,000 line is bowing up over the posterior strip. And we had a gentleman in the audience that basically broke out a calculator and divided 3,000 by 35 fractions. And he said, "Are you really trying to tell me that 85 centigrade a day makes a difference in the patient's care?" And well, yes, it does. Absolutely does. And it may not be the daily impact, but we all know that dose is cumulative. So if we can spare the posterior strip of neck and they continue to have good lymphatic drainage, then the patient will have a better quality of life. The other things that we need to take into account are the mandible and how the PTV overlaps the mandible. Obviously, we know that we can cause radionecrosis if we're not careful and try to carve the dose out of that or create contours that take that into account. The parotids are the same way. Now, we know we need to spare the parotids for quality of life, but sometimes the parotids are involved in the high dose target. So what I do a lot of times is I'll actually separate the parotid gland from the target. So you have the whole parotid and then your optimization parotids. The portion of the parotid here that is on the inside, I would just limit the max dose to. So I wouldn't try so hard to spare that region of the parotid inside the gradient zone. I would just put a max dose equal to the prescription. So you're allowing the optimizer to do what it knows it needs to do. You're just trying to guide it. Expanded PTVs, I always will create expansions based off of 5% per millimeter. So the difference in dose here for this example, we have the 7,000, the 63, and the 56. And I know I need about 5% per millimeter to achieve the difference in dose. So I expand the 7,000 by 3 millimeters, and I expand the 63 by 2 millimeters, and then subtract the lower dose PTVs from those expansions, and it gives me what becomes a gradient area. So once again, that's using a good rule of thumb, 5% per millimeter, and that's not set in stone. But 5% per millimeter is probably an average dose fall off. Sometimes it's more, sometimes it's less, but 5% works very well. Separate your targets. Ensure there are no conflicting objectives. If you have two targets that are on top of each other and they have different prescriptions, that's a conflict. Make gradient margins. If your targets are separated and you have gradients where the dose is allowed to fall off, well, then the optimizer has an easier time achieving the dose goal or the dose objective, and it doesn't have so many inhomogeneities throughout that volume. So here I created, all of my targets have been separated out. I have a normal tissue. This big khaki colored volume here is actually my normal tissue, and I create that by taking all of the targets, adding them together, expanding it by 8 millimeters, and then separating their body from that 8 millimeter expansion. The reason for the 8 millimeters is it's because it keeps the periphery of the target out of the penumbra zone, so you don't have to struggle getting dose to the edge of your targets. And then from that point on, I can ask for, maybe 50 or 60% drop in dose so that I get really good normal tissue sparing. When we optimize, obviously we want to say the targets have the highest weight. I also used spinal cord or brainstem in there because, like I said earlier, no matter how good the plan looks, if your cord or brainstem are running too high, then your plan is not probably going to be approved. Make sure you clean all your contours, optimize contours back from the skin. We need room for the dose to build up. You can't have 7,000 centigrade on the edge of the skin because, well, it's just no room for the dose to build up. And if you do get 7,000 there, you're going to have astronomical hot spots because of the side effect from trying to build dose up without the distance to do so. Evaluate the overlap areas of the OARs and your targets so that if your parotids and your high dose targets are together, you separate them out. Rings, quite often I'll use maybe down the line a little bit to help me increase my conformity. So for PTV 70, let's say I had a low conformity index, well, you can create an expansion of that 70 and maybe separate it by a millimeter, and then ask for, because of 5% per millimeter, ask for 95% dose to be the maximum in the ring, and that will help push any dose outside. It will push it back in towards the target. So another little story I like to share is a couple years ago, I went to Australia, and I was informed that their highest weight or their greatest importance was the quality of life organs, so that they would sometimes decrease or not seek full coverage on the targets if it meant that they had to sacrifice a quality of life organ, such as a parotid gland or submandibular gland or the larynx or something like that. And I respected what they were saying, but I really had to kind of talk to somebody else and just get another opinion. So I talked to a friend of mine, Dr. Mark Sobczak, works at Fox Chase, and I was asking him what his thoughts about that philosophy were. Should you underdose the target to spare normal tissue? And his quote here, I think, really hit home. And if we don't get homogeneous, uniform, full dose to the targets, we're really not doing anybody any favor. So here again is a look at the PTV-70, and this is the dose ring that I put on towards the end to help push the dose tighter to the target, increase the confirmation number. And then my beam arrangement. In this case, I used just a typical 9-beam circumferential beam arrangement, spaced equally, I think 40 degrees apiece. The reason I use PA beams is because it doesn't force entrance dose through the anterior oral cavity, and a lot of times you get better anterior oral cavity sparing, and it also helps spare your lips better because the dose is going to be more exit than entrance there, and you can control that better. Collimator rotation. I always rotate my collimator, and I've been using a 90-degree collimator rotation on the PA field almost religiously now, and the reason for that is it allows the MLCs to travel north and south, or stay over the long length of organs at risk longer, such as the spinal cord and the brainstem. The MLCs don't have to move across the target to protect normal tissue or organs at risk, and you have a little bit less modulation, it seems, and it helps the collimator rotation. It helps wipe out some of the tongue and groove effect. You seem to get a little bit better midline sparing if you rotate the PA field 90 degrees with a collimator. So how I'm setting up my prescription, ROI mean dose, so an average dose through my optimization structure. So in this plan, I created optimization structures which were separated from each other, and the PTV-70 opt was actually separated from the CTV. So I start off in intensity modulation all the time. A lot of people say, well, why do you do that? Why don't you just start off in DMPO? And the reason is because this process is very fast. 15 iterations, intensity modulation. I allow the jaws to move so it can set the optimal field size, and I don't compute final dose. I don't convert. I don't do anything. I just let it run. You don't need MLCs or a conversion or a convolution dose when you start running intensity modulation. All you got to do is just have it calculate, show you some dose, and set your field sizes. And then as I begin the plan, I optimize to my targets only. I want to make sure that I can get uniform dose to all 3 of my targets and an immediate fall off to the normal tissue. And so when I optimize the first time, if I don't see these 3 DVH lines being almost perfectly vertical, then there's a problem with my plan. There's a problem with my contours. Because right now, all I'm asking for is target coverage. If I can't achieve it now, it's never going to get any better. This is the perfect world or perfect case scenario. So from this point on, the plan is only going to degrade. So basically the first run through is just to check my targets, make sure what I'm asking is possible. You have to evaluate the tails here, and one of the reasons that I usually have 3 PTVs for each PTV is the first one is the physician drawn. And you can see as the dose is covering the target, it gets really hard, and you start to wonder, how can I control the dose in this volume? Because this is what's overlapping with the next higher dose target. So then you create a PTV eval. The PTV eval is the same as the physician's drawn, except it is not overlapping anymore. It just is abutting. It's just sitting side by side. And then the third thing I make is the PTV 56 opt. The 56 opt takes into account the gradient margins for dose fall off. And that is where you can control the tail of the dose, because there doesn't need to be any tail. It's not abutting anything. There's actually room between this PTV and the next one so that I can get nice homogeneous dose distributions and good conformity. So always evaluate the shoulders and the tails of your PTVs. And then once I get the plan looking good, I convert it to DMPO. Now, going back to why people say, well, why don't you just start here? Well, when you start an IMRT, it's a lot faster. And when you convert it to DMPO, the optimizer remembers the optimal beam weights that you have already made. So when you convert, the first portion of the optimization is basically 25 IMRT intensity modulated iterations. Then you have your big convolution dose wherever you set it. And then you have a bunch of segment weight optimizations where the MLCs are trying to match the fluence that you've already created. But by starting off an IMRT, you built your plan and given it a great starting point right from there. So this whole process only takes a little bit of time. And it gives you a good way to check what's happening. If you start in DMPO and you just add all of your criteria and hit go, it's hard to tell which structure is giving you the problem. And I always set my convolution dose midstream with my iteration. So let's say I had 60 iterations, I would have my convolution at 30. And the reason I do that is because I want the first half of the iterations to be developing a very nice fluency map. I want everything to be nice and perfectly matched for my target. And then after the convolution dose, I want it to have the same number of calculations so it can match the MLC segments best it can. I usually use about 9 segments per beam, and we routinely use 3 and 3 for the segment area and the MUs. And then obviously for DMPO, we have to compute the final dose because the MLCs have now been added, and SVD if you have it. And of course, as critical of an ingredient as planning and how you build a plan is, equally as important as how you analyze your plan. So in Pinnacle, when you're getting ready to analyze your plan on the DVH, be sure to go to the tabular DVH and set your bin sizes to 1 or less, and then copy it to all others. Now, if you set it less than 1, you can't copy it. So I usually set it to 1, copy to all others, and then when I'm analyzing my DVH, I'm getting very accurate numbers. So once again, verifying my DVH numbers, I use the specify max dose. I'll type in the prescription. I don't just look at the shoulder on the graph because, quite honestly, it's kind of hard to tell what number is there. So by setting my tabular DVH to 1, this number becomes very accurate. So now I know that I have 97% of the target being covered by 100% of my prescription. And I do that for each target. So then after I have converted it, I do 15 iteration bursts just to do kind of what I call polishing. It's basically a segment weight optimization because you're not asking for another convolution. You don't need it. I like how my plan looked. I just want to maybe have it chew on it a little bit more, move a hotspot around, maybe get a little bit more sparing. So I'll just put it in for another 15 iterations and let it optimize until it gets to 15. It does its final calc again, and it gives you a little bit more polished plan. I at least do this one time after my initial DMPO conversion. Just one more run of 15 iterations helps optimize the segment weights, because now originally you had just beam weights that were optimal. Now you have all of these 90 segments, and by running it another 15 iterations, you can really optimize those segments. Plus it gives you the chance to move the hotspot or get a little bit more prodded sparing or whatever you might need. And then once again, evaluating the target coverage. So you know once you convert it to DMPO, there's going to be some side effects from the MLCs, such as beam hardening, scatter, head scatter, if the plan heats up a little bit, you have to analyze the plan critically. So here I have just the target DVHs turned on. So the magenta is PTV 70. And you'll notice that there's 3 targets that are PTV 63. So we have the doctor's drawn that drifts into the 7,000. And then we have my separated, but it's a budding, and you'll see that drifting. And then you have the optimization, which is straight down. This is the target that I typically will evaluate for my homogeneity, because I know that the abutting targets have to have some escalation on that rim, or they'll never get to the next target. But my optimization targets, I want to be vertical. So I look at the target drawn by the doctor, and then the target separated, and then the target I use for optimization. And you'll see the 3 different shapes of the graph, and that should make sense, and it explains why it helps to use the optimization structures. Kind of the process, I know there's a lot of people that just jump into DMPO and go, and if that works for you, that's great. But I kind of do things a little bit more of in a tedious process. So I use small incremental steps, because once I do something that damages my DVH, I know what damaged my DVH. I can go back and assess the contour or make a new optimization contour or whatever I need. I kind of increase the priority on the hotspot. So if I want to control my hotspot by taking small steps, I can kind of control how aggressive the optimizer is. I increase the priority on whatever I'm trying to control. If the hotspot's falling inside of the CTV, which is great, I don't want it to be 20%, so I'll still put a ceiling on the dose limit. You always need to have a ceiling on your doses. So especially if you use DVHs. Like if you ever use max DVH or min DVH, you should always have a ceiling and a floor. Regardless of what you're doing, I think you always need to put a limit on the amount of dose you're willing to allow. Optimization max and min dose very close together, so you don't need a big window to get the dose through. And over the years I've been narrowing my window down, so I usually will use maybe a 2%, 2.5% difference between my minimum dose and my maximum dose. Separate the GTVs from the PTV so you can get the hotspot pushed into the GTV or CTV. Once you separate these two things and you put a little bit more dose control on the PTV and a little less dose control on the GTV, the dose will go from where there's high pressure to low pressure, kind of like squeezing a water balloon. The water goes where the pressure isn't. Use body constraint for extra emphasis. The body constraint, that normal tissue structure I used, helps me push the dose into my targets. Understanding the byproducts, if you have a target that is approaching the skin edge, the optimizer, or for that matter, if you have a target that's in air, the optimizer is going to try very hard to do what you're asking. And the byproduct is hot spots. It will push dose through the ceiling, but trying to get dose to the edge of a surface or in an air cavity. So if you notice that you have a lot of hot spots or dose islands, and what I mean by dose islands, look at the 103% prescription, and you'll see all these little speckled of dose. Well, you'll see the 104s and 105s usually lining the surface, and that's because the optimizer is trying really hard to get dose to that edge or into the air cavity. So just understand why it's happening. Use mixed energies if allowed. So, we all know that above 12 MeV you get some neutrons. Well, if the patient is 75 years old and 400 pounds, and the doctor understands the logic, it may benefit you to use some high energy, because he's probably going to die of old age before he dies of a secondary sarcoma from the high energy beam. But that's up to you and your physicist, and that's a hot topic for some locations. And then of course analyzing the low dose regions. So here is the 3000 isodose line and the lip contours, and you can see how the dose is pushed off the lips. Now this is something also that is very important. We talked about the posterior strip sparing. Well, the anterior oral cavity sparing is a monumental concern because this is what allows a patient to get through their treatment. If their anterior oral cavity and lips are not involved in the disease, they absolutely have to be spared so that the patient can survive the treatment and make it through the course of treatment from day 1 to day 35 without a break, because simple biology says if we can get it to 7,000 without having any breaks, we have a better chance for disease control. And once again, I was talking about the sparing of the cavity and the lips, and sparing of the OARs. A lot of times we don't even think about some of the stuff that we do. I hate to say it like that, but I was guilty of this actually. I thought that the cochlea wouldn't be close enough to the superior extent of the disease to actually have to worry about it, but it turns out it was. And we've also started to discover that we're not doing as good of a job sparing the cochlea as we should have, because in the past, most of our patients with this type of disease were older. Now we're seeing a lot younger patients that are going to live a lot longer. So we really need to analyze the dose to any structure that is within range of our targets, especially the cochlea. And here, this is the 3500 isodose line being pushed way anterior to spare the cochlea. And on the first run, I think my 3000 or 3500 line was actually encompassing the cochlea because I didn't pay attention to it on my first run. And then I realized, oh my gosh, I actually am close enough to the target there, so I had to re-optimize. And then, of course, the studies talking about sparing the cochlea and the patients living longer. So here's an image of the parotid sparing and the 3000 line being pushed in off the lateral aspect of the parotid as far as it can. And the parotid sparing and the quality of life idea behind sparing it. The parotids obviously are responsible for salivary production, and we need to spare them whenever possible. So there's a few studies, and probably the most common one that we all know is keeping the mean dose under 26 gray. But a more recent study suggests doses under 24 gray will actually have the parotid restored to full function within a year post-RT. The other structure that a lot of people forget about is the submandibular glands. The submandibular glands are actually responsible for 75 to 90% of the salivary production in a non-stimulated mouth. So these are structures that, for quality of life and normal daily function, we absolutely need to spare whenever possible. Sometimes it's not possible because they're quite often involved in the target, but when it is possible, they are something to pay attention to. And here's the study that I just cited, so that it can be up to 90% of unstimulated salivary output. So the SMG sparing is something to really look into. And then the larynx, trying to keep the patients from having aspiration problems and damage to their voice downstream is very important. So in this case, it was quite easy to get the dose off the larynx. And then finally, I did do the plan that I did was a 9-field DMPO plan. I did try a couple of attempts at a smart arc, and I got a nice plan, and it would have delivered the entire 500 monitor units in about 6 minutes, 2 arcs with independent collimators, and I spaced them differently so I would have more dose calculations in the process. It was a beautiful plan, but my DMPO score was about 3 points higher, so I decided to go with the DMPO. Now, if I was in a busy clinic, obviously my choice would probably be the Smart Arc, because clinically the plans were very, very similar, but the Smart Arc was going to be delivered in about 17 minutes less. Well, about 15 minutes less. And the other tool that I use a lot, and it's probably one of my favorite toys to play with, is biologic optimization. The biologic optimization is wonderful for organs at risk, but it's also wonderful for controlling the dose inside of your target also. So after you get dosed to your targets, if you zoomed up on a dose profile of your target, you'd see doses above the prescription and doses below. Well, one thing that biologic helps you do is narrow that gap, so you have less highs and less lows and more uniform dose distribution, because the max EUD is basically attacking the mean dose function in the target. So it's a way to help get a better uniform dose. And that is my score sheet. So you can see that I had the same trouble that everybody else did, this PTV 7000 confirmation number. This was a very tough thing to improve. But this is really a byproduct of how I plan. A lot of people didn't score well here at all because the PTV or the isodose line was expanded out away from the target too much. So if you use the rings and you use the gradient margins, it will definitely help you kind of constrict the dose around each specific PTV. Now, one of the things that happens, like in this case, you would have to normalize your plan down a little bit to get coverage in PTV 56. And when you normalize down to, let's say, from 99 to 98 to 97 to get coverage, you're heating up the PTV 7000. So the isodose line is starting to expand away from your target. And when that does that, your confirmation number decreases. So there was definitely a happy medium that you had to find there. And then this would just be the population distribution amongst my Pinnacle peers. And that should bring me to the end of my talk. I thank you for listening, and you can always find us on any of the social medias. And if you get a chance, please look at the new protocol page. Thank you.